Welcome to Everyday Economics, a weekly podcast about the economics in daily life. I'm your host, Puja Mehra. COVID-19 has exposed the weaknesses in health systems across countries. Hospitals in New York are rationing ventilators, which comes down to doctors deciding who should be given a chance to live. An article ran in the New Yorker with the headline, "How did the US end with nurses wearing garbage bags?" In India, patients treated for COVID-19 in private hospitals have received bills running into lakhs of rupees. When we take someone to a hospital and if the doctors there say this person must be put into the ICU, instead of getting a second opinion, most people run to get the money for making the payment. This is what economists call a asymmetry of information. Health is one area where the market fails because doctors have more information than patients. Because of this market failure, healthcare costs can be so prohibitive that sudden health expense shocks can drain savings, which is why many people believe that the only way to make healthcare affordable is to nationalize hospitals. Do economists have a better solution, though? My guest on the first episode of Everyday Economics is Dr. Ajay Shah. I asked him if nationalizing private hospitals is a solution to the problem of exorbitant healthcare. The answers he gave are sure to make many people revisit their views about the topic. Ajay studied aeronautical engineering at IIT Bombay and then did a PhD in economics. He has worked at the Center for Monitoring Indian Economy, the CMIE, the Indira Gandhi Institute for Development Research and Ministry of Finance. He is now professor at National Institute of Public Finance and Policy in New Delhi. His writings can be read on the Leap blog, which he also edits. I have followed Ajay's writings for a long time and I'm very excited he has agreed to be the first guest on the show. Welcome to Everyday Economics, Ajay.
Thank you. It is my pleasure to be here.
On this show, we propose to avoid jargon and we propose to make economics less boring and less wonkish. And your and Dr. Vijay Kelkar's book, In Service of the Republic, I think is a great source for people with no background on the subject. And I'm very glad to have you on the show as the first guest.
And since I'm often accused of being the wonk number one, I shall try hard to live up to your dreams.
Ajay, you're one of the most articulate and wittiest economists I have ever come across in my career, at least as a journalist.
Thanks.
Right, so today's episode is about the economics of healthcare. I chose this topic because I get a lot of questions from readers about healthcare. People care a lot about it because healthcare costs can be prohibitive. Sudden expense shocks can drain savings and even spell complete financial ruin for people. These days, people are also interested in this topic because of the COVID-19 that has exposed weaknesses in public health systems across countries. As you know, public health care, you've written about this, how stretched it is, and because of which a lot of countries such as Spain and Ireland have nationalized private hospital facilities to bring COVID-19 under control. In India, governments in at least 3 states, Chhattisgarh, Rajasthan, and Madhya Pradesh, have temporarily taken over private hospitals for treatment of COVID-19 patients, invoking emergency legal provisions. The treatment for COVID-19 patients in these hospitals is going to be free. The modalities for reimbursements or the sharing of costs between the state governments and these private facilities, all of these services rendered would be in the nature of corporate social responsibility is not clear yet. But what has happened is that a lot of people have come to believe that the best way of dealing with COVID-19 is for nationalization of private health care. In fact, there was a plea for this also in the Supreme Court, which got dismissed. What I would like to do in this episode is to get your views on if nationalization of private healthcare is the right policy solution for dealing with the COVID-19 pandemic, and especially for a country like India with a large health infrastructure deficit, and understand if there is a problem in understanding the nature of this problem, and that is leading people to think that the solution is nationalization. But before I come to that main question for this episode, I want to start by asking you to please explain what is the difference between public health and health, as you have described in your book, and why it's important to understand this distinction before we get into any conversation about health policy.
Yeah, the word health contains two very different activities. One of them is public health, and the other is healthcare. And we tend to mix up these a lot, and that is a big problem of this field. Healthcare is straightforward. I have a toothache, I go to a dentist, I occupy the chair in the dentist clinic for a certain period of time, and I get cured, I get better. This is what we economists will call a private good. It is my cost, it is my problem, it is my toothache, it is my happiness that the toothache got cured. There are limited larger ramifications of this. It's an individual consuming a service, and it is not a population scale intervention. This is what we call healthcare. Okay. Public health, in contrast, is interventions at the level of the population. So, for example, when we build immunization systems, when we track communicable disease, when we organize responses to epidemics, when we control disease vectors, whether they are mosquitoes or rats, these are interventions that matter at the level of the country, at the level of the people, and not at the level of one individual. That is the subject of public health. So these words are very confusing. Public health is not the health of the public. Public health are the activities that influence the entire population and not any one individual. Healthcare plays out one individual at a time, and it's a completely different kettle of fish. Now, in the world of public health, there is clearly an important role for the government. Only the government will mobilize a campaign against mosquitoes. Only a government will support the research and development that goes into building a new vaccine. And governments tend to have an important role to play in immunization campaigns, though it does not have to be the 100% domination by the state that we have seen in India so far. Whereas in contrast, in healthcare, you can actually do a lot without requiring too much of government. There are problems. Healthcare is a difficult field where there are difficulties, where there is market failure, but it's much more a conversation between a private services provider and a private individual. So healthcare is very different from public health. The last difference I will emphasize is that public health is reasonably cheap. Healthcare is very, very, very expensive. So when you think from a public finance point of view, it's not a difficult thing, and it's a very sensible thing to put substantial public health work on the shoulders of the government. But when you think of healthcare, you have to be far more circumspect because the amounts of money involved are simply staggering.
In your book, you have described how India's done fairly well on some objectives of public health. Do you want to talk about that now?
Yeah, the great success stories of India in public health are the eradication of smallpox, the progress we made on the polio vaccine, the significant improvement in the quality of drinking water, and hence the decline in diseases like diarrhea that has happened all across the country. So these are some of the important wins of public health in the country. But I would also say that compared to other countries of our level of income, we're doing pretty badly in public health. And here, you should really not see India as a monolithic country, but India should be seen as a continent. We are like a European Union. We are many, many states of India where conditions are dramatically different. So, in places like Tamil Nadu and Kerala, there is a significant public health capability. We can actually track contacts and trace and isolate the people who have been affected by an infectious disease in a place like Kerala in a way that's much more difficult to do elsewhere in the country. So India is not a monolithic country. India is many, many widely divergent countries which need to be seen in their own light. So thinking about UP is different from thinking about Rajasthan. And we make a mistake when we think about India in a monolithic way.
And do these differences primarily have to do with state capacities?
Yeah, state capacity is the central problem that affects the Indian state and the heterogeneity of local conditions. But also local conditions differ. Temperature differs. The problems of Rajasthan have to do with much more lack of access to water. So you want to think about water and sanitation and the consequential public health consequences in Rajasthan differently from how you might think about them in Orissa or in Kerala. So, local conditions predominate. The disease burden of different diseases is different. In West Bengal, you've got to worry about arsenic. In Assam, you've got to worry about arsenic in the water. So there are different problems in different parts of the country. And again, that is why it is important that we need to go in a much more decentralized manner in having local control, local research, local analysis, local data sets, local responses to the problems that are present all over the country.
And I think probably that's why it makes a lot of sense for health to be a state subject like it is in India.
Yeah.
Uh, to talk first about issues in private healthcare, and this is something that most listeners will relate to. Um, Conflicts are inherent in the business of medicine. Whether openly they're visible or not, there's always going to be a dilemma between the pursuit of private profit versus public service. We see this drawing out in the real world as medical industry chasing revenue targets, which is sometimes not very different from companies that push sales of detergents or watches, things like that. And a consequence of this often is that private healthcare providers tend to overprescribe tests or procedures. This has been observed in the rates of cesarean sections for childbirth or even antibiotic use in general practice. This is a familiar problem to economists. Could you explain these economic phenomena at work here and also talk about possible solutions to these problems when we are talking about private healthcare?
Yeah. So many times in the Indian discourse, uh, doctors lay claim to some kind of nobility, that doctors are uh, self-effacing social workers who are doing good things for all of us. And we economists are cynical and we think that everybody works for their self interest. So, whether we think about a politician or an official or a doctor, we always think through the lens of self interest. And I think there is much merit in applying this kind of framework to the world of doctors. And what we see all over India is that doctors are in a position of trust and they often abuse that trust, as you mentioned, over prescribing tests and procedures and antibiotics. There are blatant violations of fair play when a testing lab or a drugs company pays the doctor a kickback directly proportional to what the doctor has prescribed. That really makes you extremely uncomfortable. And it is a tragedy that all over India, this is the norm and not the exception. All over India, the testing labs and the drug companies have managed to establish information systems whereby every single prescription that is signed by a doctor is attributed to the doctor, and the doctor gets a kickback in proportion to the drugs and the tests and the procedures that the doctor has prescribed. This is really, really appalling, but that is what is going on all around us. But as you said a moment ago, you know what? This is not new. We've seen this in many, many places, most notably in finance. We know how badly these things work because there are financial distributors and financial advisors all over India who are doing these kinds of things where there is some LIC agent who gets a kickback from LIC and goes around selling insurance policies. We've had a giant ULIP scandal where the insurance companies were hypercharging their distribution channel, mostly banks, and paying kickbacks to the banks so that the banks would do mis-selling and get individual consumers to really get ripped off when they were buying their financial products. So this misbehavior by the medical profession is not exactly new. We have seen this in many areas of economics. I want to underline the tragedy of this misselling. This misselling is really, 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 really damaging in the field of health. And this has to do with the distinction between prevention and cure. Okay, when I get early stage diabetes and I go to the doctor, the incentive of the doctor is for me to stay sick, for me to be chronically unwell, for me to visit the doctor 100 times in the following 20 years, and to suffer all kinds of medical procedures and drugs, because that is how the doctor makes money at my expense. Whereas the doctor will not emphasize the behavioral changes, my weight loss, my exercise, my diet, through which actually diabetes is largely controllable in most people at an early stage. This is just a complete tragedy that the doctor should be my trusted expert who should be guiding me on how to be healthy. Instead, the doctor is incentivized to send me down the slippery slope of becoming more unwell so that I will come back and pay more and more money to the medical profession. This is just something truly sad that is happening all around us in the world of healthcare today. And this is what we economists term the market failure in healthcare.
Right. I don't know how many doctors and family members of doctors are listening to this show, and probably they won't listen beyond this point. Nevertheless, not to make sweeping statements, but this is what this is how the incentive works. This is not to say that everybody functions like this. Every field has its exceptions, and I'm sure there are doctors out there who are not as driven by profits as some other profit-driven people in other sectors are. But this is, like you said, not new or unique to doctors. We've known this for more than 100 years now, that private practitioners cannot be relied upon, at least for public healthcare.
Yeah,
There's this old tragedy play that I think brings out this rather well. I'm talking about the tragedy play, The Doctor's Dilemma by George Bernard Shaw, which was first staged 114 years back. The
yeah,
lead character in this play is a doctor who has developed a revolutionary new cure for tuberculosis. His private practice has limited staff and beds, and so he can only treat 10 patients at a time, which
yeah,
leaves him with the only option of rationing his treatment, much like what we're seeing in hospitals in New York right now that are rationing ventilators to COVID 19 patients as we speak. This
yeah,
plays doctor selects 10 from a group of 50 patients because he believes there's greater need to save the ones that he has chosen. But
yeah,
an old friend of his and a colleague also needs this treatment, and so the doctor must choose which patient he's going to save. Is it going to
yeah,
be a kind, poor colleague, an extremely gifted but also unpleasant, amoral young artist, or the woman that he has fallen in love with? And I think people seek state interventions for this very reason. When they see a doctor deciding who gets to live, they want to place their trust in the state to make these decisions. And that's why I think they begin to ask for nationalization of private healthcare when there is something like the COVID 19 happening. And this brings me to the main question of this episode, which is would you say that in times of public healthcare crisis, nationalizing private healthcare can help?
well, I cannot resist. You just said that people get attracted to bringing the state into it. And then I immediately want to say, but the Indian state is a deeply flawed creature. So
This
we
is a
should
strange
not think,
paradox. This,
hmm?
this is a this is a strange paradox.
Yeah,
People in general do not trust the state, but whenever there's a problem, they want to look at the state as the backstop.
yeah. So, in some dream world, we would be in some Ramrajya where the Indian state is omniscient and omnipotent and benevolent, and we would all be taken care of. But excuse me, that's not the world that we live in. We live in surrounded by a deeply flawed state. The Indian state is not able to see reality effectively. The Indian state is not benevolent. It does not work for the best interests of the people. And the Indian state has very limited capabilities. So uh, it is nobody's case that private healthcare works very well. But we've got to ask the question that when state capacity is limited, what use do you want to put to it? What are the most limited interventions that the Indian state can actually execute successfully, through which maybe you can make some progress to solving these things. And maybe there is a large part of this problem that cannot be solved. So I think a large dose of hesitation and skepticism about state power and state intervention would go a long way, because we in India have seen a long litany of woe where the Indian state has gone from mistake to mistake to mistake. Okay, from 1947 onwards, we are one long story of state failure. So we should not be too optimistic about what the Indian state can do. So let's think about it in a small practical way, and later on we can think about the deeper conceptual underpinnings. So let's be very practical. All of us have seen government hospitals. So, in Bombay, you've been to Sion Hospital. In Bombay, you've been to KEM. In Delhi, you've been to RML. There are many, many government hospitals, and we know how they work. We know they work badly. So, hypothetically, if you nationalize all the private hospitals of India, you will convert all these hospitals to the low levels of performance of government hospitals. So it's like saying that we will take over all the airlines and we'll convert all the airlines into Air India. It's like saying we will take over all the private banks and convert them into the working of PSU banks. It's like saying we'll take over all the telecom companies and convert them into MTNL. Okay, this is a movie that we've seen before. So the problem with this solution is that it has been tried. There was a time in India when pretty much all the hospitals were government hospitals. And there's a reason why private people chose to go away from government hospitals to private hospitals, because private hospitals performed better. So, with all the criticism that I would have of market failure in the private hospitals, the point is people are choosing. Okay? That there are some people who have the choice of going to a government hospital who are instead choosing to go to a private hospital, and that is surely something we should respect. We should respect private choice. That it would be a sad country where MTNL is the only phone company. So I think this is a small practical thing that we should think about. Another small practical thing we should think about is, okay, very well, you've gone and nationalized the hospital, and so you've put some government management on the hospital. You've moved all the doctors to government salaries. Now, who's going to manage the hospital? Because a lot of the individuals, the employees of these hospitals will leave. They will not work in a government hospital. It's like saying that many of the employees of a private bank will not work if you nationalize the private bank and say to the employee that now I'm going to pay you at the SBI salaries. So you will nationalize the government, the private hospital, and you will switch the management of the hospital into a governmentish management system, and you'll move the salaries of all the doctors to the salaries of civil servants. Very well. Two-thirds of the employees will walk out in a week or two. And then what? What are you going to do? So, at a very practical level, this solution falls apart in no time. Or you say, okay, fine, I'm not going to nationalize this hospital, but I will use state power and I'll point a gun at the owner, at the manager of the private hospital, and I will say, you must work for free. Okay, how is that going to work? Let's just think about it at a personal level. Suppose somebody comes and points a gun at me and says that you got to do your work for free. How am I going to respond? Am I actually going to do the work? Am I going to run away? Am I going to slack off on the work? Am I going to do bad quality work? Will the capabilities of the organization survive this kind of large intervention that you're thinking of building? Okay. And then finally, let's think of incentives. At present in India, for all practical purposes, some 70% of the healthcare capacity in the country is private. Roughly speaking, 70% of the testing labs, of the clinics, of the OPD, of the hospital capacity is private. If the government nationalizes this and expropriates these people, then for the next 50 years, will private people feel safe investing in healthcare again? Okay, nationalization is a very, very costly thing. because it effectively says to private people that, you know what, you can build an organization, you can put your financial and emotional resources into building an organization, but I can kick you out and you can be expropriated, you can lose your family jewels because some government guy decided to do so. So for 50 years, we will suffer the adverse consequences because no businessman, no family, no entrepreneur enjoys being nationalized. And people will not invest in India in building organizations when they see the government nationalizing organizations. This will be not just in hospitals, it will also be in other areas. We have seen this movie before. We know what happened when Indira Gandhi nationalized hospitals. We know what happened when Bhutto nationalized a significant chunk of the private firms of Pakistan. For 30, 40 years, this damages the growth prospect of the country. So we should think 5 times before we go down these things.
And also, on a more immediate note, if private healthcare facilities were to be nationalized, as in a limited way we are seeing in these three states I spoke about, and the treatment being given there is not going to be paid for some time, any private hospital will be able to absorb the costs through their cash reserves or even their CSR. But after a point when these run down, nobody is going to run an operation out of their personal money, and even that is not unlimited.
You're being too kind. Uh, if I'm a private firm running a hospital, why should I run for even one day without revenues? It's not
Absolutely,
fair. Why would I
absolutely.
do that? When side
Especially
by
when you're
side, there are
talking
other
about,
hospitals who are not being nationalized, when there are other states who are not doing this nationalization.
and you have fixed costs, you have loans to repay, you have salaries to pay. Where is all of that going to come from?
And you have put capital into this enterprise, which has to earn a fair return on capital. So, nationalization is a very costly thing. So, I'm reminded that I think it was in Andhra Pradesh, a new government came to power and they reneged on a large number of contracts on
Yes.
infrastructure contracts. Uh,
Yes.
and I think that has consequences. Then the private sector will start thinking, okay, I don't trust you. So in the future, when the state government tries to establish infrastructure contracts, people will be 5 times more circumspect before they will trust that state government again. In that same fashion, in the states where healthcare facilities have been nationalized, you will have greater hesitation by private persons in the future about establishing new healthcare facilities because you worry that, can I trust this government? If I'm not safe from being expropriated, why will I invest? This is an absolutely basic question that every private person can and should and will ask.
Right. But I want you to also talk about now of the other way of looking at this and what you think of that, which is that, health is essential after all for human welfare and even economic progress because quality of human capital depends on it. And when you provide health on the basis of ability to pay instead of on the basis of medical need, then you end up denying healthcare to a large section of people who can't afford to pay for it. And that is how our current system is right now. It caters to a very small section of the population which can afford to pay for healthcare. And I'm not talking of public healthcare, I'm talking of healthcare. How can this be remedied?
It's not easy. So let's go step by step and think a bit about how to go about it. Let me first switch gears completely and talk about an idealized state of the world. In the idealized state of the world, there is an organization that is called a HMO, a Health Maintenance Organization. An HMO is a network of healthcare providers who come together under one banner. You become a customer of the HMO and you pay the HMO, say, 1,000 rupees a month as a flat cost for the rest of your life. And the HMO says, I will take responsibility for all your healthcare requirements. Okay. So the HMO is a bundle between health insurance and healthcare. Why is this such an attractive structure? Why is this such an important idea? This is such an important idea because now the incentives of the HMO have turned upside down. Now, the incentive of the HMO is that you should not get sick. The bias between prevention and cure in a normal private healthcare organization, the bias is in favor of more healthcare. They want you to be more sick because you will come back to them and pay them more and more money over the years. Whereas in an HMO, if you stay healthy, you're paying them 1,000 rupees every month and not making any demands on healthcare services, then actually they make more money. So this is one deep idea that it is absolutely essential to turn the incentives of the healthcare provider away from increasing my sickness towards increasing my health. And that requires a fundamental re-architecturing of the nature of the relationship between the healthcare system and the individual. Now, if you start trying to head in this direction, we will hit certain barriers. We will hit a barrier because the present healthcare system is based on widespread malpractice. So, if you are a doctor in the present malpractice ridden system, you're making a ton of money out of the malpractice. Why will you go work for an HMO type organization where you actually make less money? So, it's a bit like saying that when the insurance agents are doing mis-selling, how do you become an ethical person selling index funds? Okay, it doesn't work because the employee of the financial B2C organization will always say, I want to do malpractice like everybody else, and I want to make millions of rupees just like everybody else. So, this is problem number one, that if some good people come together and try to start an HMO, they will face intense resistance from doctors, where at present, doctors are making ill gotten gains out of the pervasive malpractice that is there in the Indian system. And so that takes you to the first milestone that we've got to work on in India today, which is regulation. We need some basic foundations of fair play and malpractice and regulation in the world of medicine. For example, in finance today, we increasingly understand that if an advisor is getting a kickback, then that is completely unacceptable. That a manufacturer cannot give a kickback to an advisor to get you to buy a certain product. Well, that's the first important milestone that we've got to reach in the field of healthcare. That if a drugs company or a testing lab or a hospital that does a procedure gets a kickback from me when I prescribe that expensive activity, then that should be considered completely anathema. We've got to establish that regulatory machinery where these rules of the game are established and they are enforced. So, this is my sense of where we are going, that we are starting from ground zero. We've got an extremely bad set of incentives in Indian healthcare. We've got to go to some basics, some foundations. We've got to establish some legal machinery of malpractice, of regulation, of conflicts of interest, where we've got to rein in the misbehavior of the present industry. And then side by side with that, some HMO type structures can come. And then maybe in some 20, 40 years, we'll get to something better. But in the short term, I do not know how to make progress on addressing the challenges that you outlined.
Right, and a lot of people talk about extending healthcare to the people, poor people, through cash transfers or income supplements or a universal health insurance. Can such interventions work in the interim until the HMO structure that you've spoken of can be implemented?
Yeah, so I'm in great favor of redistribution through cash transfers because then the individual chooses what is the best application of that cash. So whether that money should be spent on buying potatoes or healthcare or alcohol should be the birthright of the individual. So I am a great believer that cash transfers are better because it respects the judgment of the individual. That what is the life of the individual, what is the point of pain of the individual, the best understanding is that of the individual. Now, when you come to the healthcare side of it, the problem is that the individual is then stuck dealing with this bad healthcare system. So, for example, we tried to build a government funded health insurance system that was called RSBY. And The problem that RSBY encounters is that private healthcare providers work reasonably badly. There was a large scale of fraud where people would engage in a fake transaction with a healthcare provider, and the individual would claim that I had a knee surgery or I had an appendicitis, and the government insurance system would pay money to the provider, and the individual would get a cut from that payment. So until we've laid some better foundations of how we control the behavior of the healthcare system, it doesn't just work to inject a layer of public payment for health insurance on top of that. This is the problem that bedevils Ayushman Bharat as well, that we've not solved the deeper market failure in private healthcare. We're just trying to put a layer of public funding on top of it. And we have no guarantee or ability to assess the quality of services that are being rendered by the healthcare system, which could be low, which could be overprescription of procedures, tests, and drugs, which could veer into outright fraud. These foundational things have not been done. So when we look at a country like the UK, it's great. They've got an NHS, it's a very nice system, but that doesn't mean you can import it into India right now. We've got to look at our conditions in India right now. I think that the frontier for India right now is basics of law, regulation, malpractice, improving the incentives of the healthcare industry, dealing with absolute basics of consumer protection, and maybe in about 5-10 years, getting to the point where we are able to block the kickbacks. So my 5-10 year aspiration would be, can you put an end to the kickbacks?
And also, I think maybe just more supply of healthcare. I had visited AIMS a few months back, and it can truly be a completely life-changing experience. I'm not exaggerating. There were people waiting for treatment on practically every single inch of the campus. It seemed to me like the whole country was there. There were just people looked so unwell, they looked like they were helpless, they were in distress. It can be a really disturbing sight that so many people have nowhere to go for basic healthcare needs such as fevers, etc. And I think it must be really difficult for poor people uh, to access private health because one sickness in the family can just push them back into poverty. So is just also increasing the supply of healthcare infrastructure a solution?
So when you say aims, you have to keep in mind that this is government produced healthcare. That's a different kettle of fish. That has the management crisis of government produced anything. So this has the MTNL problem. This has the Air India problem, that we have a government that does not know how to run these kinds of complex organizations. So we should not be holding our breath for the government to be able to build government facilities that work reasonably well anytime soon. AIMS is the best example of what a government hospital can be. Everywhere else in India, there are thousands of government run facilities which work less well than AIMS. So, really, if you want to scale out the magnitude of these facilities, we've got to look at the private sector. And we know that the private sector has these problems, and there's no easy way around those problems. I also want to emphasize that there is a very important problem in this country, and that is called poverty. When people are poor, they cannot afford to do certain basic things. So I could equally tell a story that eating vegetables and fruits is absolutely fabulous and important, and it would make a world of difference to the lives of people if they ate more vegetables and more fruit. Okay, so you and I probably get half of our calories from vegetable and fruit, while poor people in India get maybe 2% of their calories from vegetable and fruit. And that's a terrible state of affairs. But the solution to that is not a government that starts dispensing vegetable and fruit. The solution to that is called economic growth. So we should absolutely run, not walk. We should be desperately focused on getting India to high GDP growth. From 2011 onwards, India has got into low GDP growth. And it should be our highest priority to get back to high GDP growth. But until you get to prosperity, you cannot solve the problems of the country. So we should not single out health saying that oh, health is so important and we've got to somehow solve health while being a terribly poor country. No, it won't work like that. The primal problem we've got to solve is poverty. We've got to become a rich country first. That is our highest priority. Once you become a rich country, a lot of problems are going to get solved automatically and people will lead better lives.
Deprivation does get taken care of to a large extent with increased growth and prosperity. Suppose Pakistan attacks us. Suppose that the government says that the fiscal deficit is a big problem, so we can't protect all Indians. We are going to protect only the poor. Let the rich protect themselves. We don't really have this debate when we talk of the army, the navy, the air force, on whether it should be in the public sector or the private sector, but we do it for health. Just like there can be no army or border protection for only the poor and not the rich, can there not be a solution where we have only healthcare, government provided healthcare for both the rich and the poor? And when he said this, it sort of, this line of thinking led me to two questions. One is that a lot of people resent having to pay taxes because they feel it ought to reduce their out of pocket expenses on health, on education, on security. They don't like to pay taxes to finance health exclusively for the poor. Would you change your view a bit, and would you favor public provision of health, not public health, health, if tax collections were not a constraint? I know you've spoken of the capacity issue, but that again, this particular economist said that, the quality of a public service usually depends on whether the elites are using it or not. Take the example of railways. For as long as the elites and the upper middle class were traveling by trains, the coaches and the platforms were quite clean. The service was bearable. As soon as this class of consumers started shifting to low cost airlines, the quality of the service of the railways also started deteriorating. So, if this is true, then the capacity issue that we've discussed probably gets addressed a bit. Would you say it gets addressed a bit? And the second thing is that, is the problem here targeted interventions? If we do not make targeted interventions for just one section of the population, which is the poor, and if we instead aim at providing it to everybody, the rich and the poor, will that change things a bit, according to you?
Okay, let's go one by one. First, when it comes to defense, we are comparing apples and oranges. Defense is a pure public good. It is non-rival and non-excludable. It is non-rival in the sense that your consumption of higher Indian safety in no way comes at the expense of my consumption of higher Indian safety. And it's non-excludable in the sense that it is not even in theory possible for a newborn child to be excluded from the umbrella of safety that we have because there are armed forces. Neither of these two conditions applies in the problem of healthcare. Healthcare is a private good. It is rival. When I'm sitting on a hospital bed, it is a hospital bed that you cannot utilize. It is excludable. It is in theory possible to exclude a newborn child from utilizing the services of healthcare. So there is a very simple theoretical foundation why there is a population scale intervention for defense, but not a population scale defense intervention for healthcare. And note once again, when I say public health, when I say controlling mosquitoes, that is purely government's work. Only the government can combat mosquitoes. There is no individual level solution to kill the mosquitoes. I mean, we can put mosquito screens on our windows, but when we step out to walk on the road, we will be bitten by the mosquitoes. So only the government can do public health. Only the government can undertake population scale interventions, and that is where I say, without hesitation, that that is the work of the government, and there should be full resourcing for those things. And by the way, the amounts of money involved are not very large. It's not difficult to afford a pretty good public health activity being run inside the government. But turning to healthcare, first, it is not a public good, it is a private good. Second, the world that you describe of a government dominated healthcare system is actually where we started. Okay, so if you look back 50 years ago, there were no private hospitals in India which made profits. There were just philanthropy and there was government. So there were philanthropic hospitals and there were free government hospitals and there was nothing else. That's where we started from. Why did the world change? The world changed because of the MTNL problem. Just like PSU banks and Air India and MTNL and myriad other government activities we do not have that state capacity. We do not have the ability in the Indian state to run healthcare facilities at a plausible level of competence. You have used AIMS as an example. I can show you government hospitals all across the country where the state of conditions is absolutely appalling. We have hospitals in India where not a single surgery happens because either there is no oxygen or there is no anesthetist, or the critical drugs that are required to go through with an operation are not present inside the hospital. We have a pell-mell collapse of state capacity in India over the last 30, 40 years. So I would always say you do not put money down leaky pipes. Let the government system develop higher capabilities, and then we should reassess our trade-offs. So I'm not at all dogmatic about what to do in the government, what to do in the private sector. But given the present state of capability in the Indian state, we should be asking the Indian state to do a few minimal primal things. I always use the quotation of John Maynard Keynes that the job of government is to do the things that nobody else will do. So you need the government to run the army because nobody else will do it. You need the government to run the courts because nobody else will do it. You need the government to run a tax system because there can be no government without some tax revenue. But beyond that, do you really want to mission creep the Indian state into doing 500 other things which are really not unique to what the government can do? I would question that. We in India are at the early stages of maybe 25 years or 50 years of learning basics of how to run a government. And we should focus our limited state capacity on doing a few things that only the government can do, which private people are unable to do by themselves. For instance, it would be nice if the government would fight with the problem of air quality in North India.
Yeah, and I'm reminded also of the Gorakhpur hospitals where little babies were not provided oxygen supply in time, and that's typical example of how the state fails and how government hospitals fail to do simple, essential things. Uh, Close to the end of the episode, I just want to ask you one thing, which is that is there a need for us to expand our what we include in public health? And I say this because I'm reminded of the film Joker, in which Gotham City's budget cuts deprive Arthur Fleck, played by Phoenix, and I'm not going to say his first name because I try very hard, but I can never pronounce it. But Arthur Fleck is denied psychiatric treatment because of the budget cuts, and this precipitates his health issues and it leads him to commit crime and murders.
Yeah.
Uh, in India, we of course do not even think of providing mental health care as part of public health, but should that be a goal at some point at least? Or is it
So,
all right to cover only infectious disease
so
in?
see, in my dream HMO setup, mental
Yeah.
health issues would very much be part of the class of issues that the HMO would cover. But thinking practically in India, the dominant idea to think about in all public policy questions is low state capacity. We, the people, are the principal. The Indian state is our agent. The Indian state has very, very low capabilities and will always pursue the interests of the functionaries at the expense of our interests. So we've got to grapple with this principal agent problem. We've got to get this agent under control and make him deliver results for us. And the path to doing that is to narrow down the work of the state to a very short agenda and hold the state accountable and get results. Once we learn how to get a state that does a few things well, then maybe we can broaden out and do a little more. But in sequence, our first priority is to turn the balance of power. Too often in India, we are in a colonial environment where the Indian state is the ruler and we are the subjects, and we are endlessly subject to oppression. We should turn it upside down. We, the people, are the principal, and the Indian state is our agent, and we are able to hold the state accountable and get performance for three things. And pick three most fundamental things, pick five most fundamental things, and make them work, get results, get accountability, get the state under the control of the people. And then after that, we can think of enlarging the mandate of the state.
Right. And to end the episode, for those of my listeners that want to know more, find out more about economists' views of healthcare, would you please share your reading recommendations for books and articles? I would highly recommend the chapter on this particular theme in your and Dr. Kelkar's book. But is there anything else you think readers can read?
Yeah, if you will Google for the Leap blog, there are lots of articles building on this intellectual framework.
The lead blog is the blog where Ajay's articles can be found. It's also the blog that he edits. And I highly recommend the blog as well. Thank you, Ajay. Thank you for speaking to me on this first episode of the Everyday Economics podcast.
Thanks a lot, Pooja. This is great.
Thank you.